Hello, everybody. We're going to give some time for everybody to get on, and then we will be getting going. Dr. Vermillion, can you see my screen?
I can.
Okay, perfect. Just wanted to double check. Okay, I'm going to give it another minute, and then we will begin. Okay. For the interest of time, I'm going to get started. My apologies. Hello, everyone, and thank you so much for joining us for today's presentation. My name is Alexandra Walsh, and I am the coordinator of programs at the Tourette Association of America. We are the only national nonprofit providing resources and support to those with Tourette syndrome. Today's program is sponsored by our cooperative agreement with the Centers for Disease Control and Prevention. As a reminder, the views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. TAA is currently in our 19th year of partnership, and with their support, we are able to provide this presentation today on anxiety and Tourette syndrome. With me today is your presenter, Dr. Vermillion. Dr. Vermillion is an assistant professor of neurology and pediatrics at the University of Rochester, New York, where she is also the director of the Pediatric Movement Disorders Fellowship. Dr. Vermillion received her Bachelor's of Science from Vanderbilt University and her MD from the University of Rochester. She completed a residency training in child neurology at the University of Rochester, where she stayed on to complete a dual fellowship in pediatric movement disorders and experimental therapeutics. She then joined the faculty at the University of Rochester in 2019 and currently co-directs the Tourette Association of America Center of Excellence at the University of Rochester. Dr. Vermillion has an active research program focused on tic disorders and co-occurring conditions in youth. She also directs the University of Rochester Batten Center, studying the natural history of and treatments for Batten diseases. Clinically, she specializes in pediatric movement disorders with a special interest in Tourette syndrome. Dr. Vermillion currently serves in the Scientific Program Committee at the CNS. She previously served as a member on the editorial board for the resident and fellow section of the Neurology Journal as well. Our mission statement at the Tourette Association of America is that we are dedicated to making life better for all people affected by Tourette syndrome and tic disorders through efforts that raise awareness, advance research and understanding, and also provide support. We have 3 pillars. Awareness, research, and support are our 3 main pillars of our organization. And through these, we are able to provide our community with many resources. Awareness. Through social media, public relations, and news placement, as well as our youth ambassadors located across the country, we raise awareness of Tourette syndrome. This is also done through advocacy and lobbying on Capitol Hill for continued funding of our programs. Research. By providing grants and fellowships to both young investigators and other professionals, we can advance research and support clinical trials on Tourette syndrome and the discovery of new treatment options. Support. The TAA manages a network of chapters and support groups across the country that provide local support for the community. In addition to this, we host numerous programs such as online support groups and educational webinars and presentations that provide additional support to our constituents. The TAA also hosts a provider referral listing where providers who may be treating patients with tics and tic disorders can be added to if they would like to be contacted. If this is something that interests you, please reach out to us at the TAA at support@tourette.org. Resource development. Our partnership with the CDC allows us to create a library of comprehensive materials in a variety of languages about Tourette syndrome and tic disorders. These guides are free for the community and support children, young adults, educators, medical professionals, law enforcement, and patients and families. They are available both online and in print for you and your patients in 17 languages. I am going to close my slides. And I'm going to make Dr. Vermillion the presenter again so she can share hers.
Okay, thank you so much.
You can start your presentation. Thank you.
Awesome, thank you. All right, you can see my slides okay, Alexandra?
Yes, I can.
Wonderful. So thank you all for the opportunity to be here with you today, talking about a topic that is near and dear to me, anxiety in Tourette syndrome. There are three main learning objectives for what we're talking about today. One is to be able to improve the understanding in the medical community about how we screen for, how we diagnose, and how we manage anxiety symptoms in individuals with Tourette and tic disorders. I want to help improve the knowledge about the relationship between anxiety and tics and how these might impact youth and also adults actually with Tourette. And then we'll talk a little bit about managing anxiety and options for managing anxiety in individuals with Tourette. I do have research funding from the CDC, although I won't be talking about any of the work from that today, and I'll be discussing some off-label uses of medications. So to start, what are tics? So tics are sudden and recurrent movements or vocalizations. They're stereotyped such that each one that's done looks the same or sounds the same every time, and they're non-rhythmic. What we know about tics is that they tend to wax and wane over time. So that means there might be periods in someone's life where they have many, many tics, or tics are very, very frequent, and times where there are very few to none at all. And they also can change over time, such that there might be certain tics that are present for a period of time and go away. Sometimes new ones can crop up, old ones can come back again. So there's this sort of ebb and flow that can occur with tics. When we are diagnosing tics or tic disorder in an individual, and this is usually done in childhood, it's really based on taking a very careful history and doing a good neurological exam. The neurological exam allows you to observe the sounds and movements, but also allows you to assess for other potential etiologies. And the history is really key because you get a lot of the clues that these are tics or tic disorder from that history. And a very important piece of that is engaging the child as well. Ask them why they're doing what they're doing, and they will often direct you to the reason. For most people, they do not need imaging or other tests for a diagnosis. It is typically a clinical diagnosis. So this is a diagram from the Tourette Association of America that I think very nicely lays out the experience of somebody with tic disorder or Tourette. So the diagnostic criteria for Tourette syndrome or other tic disorders hinge on the presence of vocal and or motor tics. And that's often what somebody is coming to me in the office asking about, these tics that they're having. But it's also important to recognize that there's a lot that might be going on underneath the surface that they might not bring up as their initial concern, but can be a big issue for these patients. And there are some of those represented here in the diagram, such as ADHD, OCD, anxiety, what we're talking about today, and other symptoms. And so it's important to ask about these because the vast majority of individuals with persistent tic disorder, such as Tourette syndrome, has at least one of these co-occurring conditions. And many people will report that these co-occurring conditions or symptoms are more bothersome than the tics themselves. So it's important that we screen for them. So of all these different things that are in here, why am I focusing on anxiety? There are a number of reasons, and I'm going to try to lay out some of these in the talk today. One is that anxiety disorders are common in Tourette syndrome. Anxiety is something that might actually start quite early in an individual with Tourette syndrome and can persist or sometimes increase over time. Anxiety symptoms do have a negative impact on individuals with Tourette syndrome. And we also know that there is an interaction between anxiety symptoms and tics. So it's important to understand that relationship. Stepping back and thinking about anxiety disorders overall, what is an anxiety disorder? Anxiety is a normal reaction to certain situations. It would be normal to feel anxious or worried when you're in somewhere and you see a bear, for example. But what happens in anxiety disorder is that you get excessive symptoms of worry outside of the level of the trigger. And these symptoms persist. And depending on the type of anxiety disorder, the duration of symptoms that are needed to fulfill criteria for anxiety disorder will differ. But these symptoms are distressing or impairing in some way to the individual. And while we often will say anxiety or anxiety disorder as an umbrella term, there are many categories of anxiety disorders that are based on the types of symptoms that are present. So these are things such as generalized anxiety disorder, separation anxiety disorder, and social phobia, for example. When evaluating an individual where you think that they seem anxious and anxiety is part of what's going on, it's also important to think about the medical differential. And so here's a list here of some different medical conditions that can be going on that can look like anxiety. But oftentimes, from a good history and evaluation of an individual, you can rule out some of these conditions. And then there's some extra testing that can be done if you're not quite sure. Anxiety is a cycle. There's a trigger of some sort, and so the individual responds to the trigger, and that will lead to avoidance of a trigger. And so when the trigger is something that is part of everyday life, for example, for a child, school, that's something that they will still need to participate in, that avoidance can be maladaptive and cause a problem. Going back to Tourette syndrome and tic disorders specifically, I had mentioned before that anxiety disorders are common in Tourette syndrome. And there have been a variety of studies that have looked at this. The frequency or prevalence of anxiety disorder diagnoses do differ depending on the way that the studies are done and the way the information is collected, but somewhere around a third to a half of individuals with Tourette syndrome or other persistent tic disorders have a co-occurring anxiety disorder. The most common one that's been reported most often in literature is generalized anxiety disorder, but there are other common types to consider. Social phobia and separation anxiety disorder are two common ones that we think about, especially in youth, so children and adolescents. But it's important to think beyond anxiety disorders and to think about the symptoms as well, because to have an anxiety disorder diagnosis, you have to have a certain number of types of symptoms that have to be present for a certain amount of time and be impairing. But it's also possible to have symptoms of anxiety that are bothersome or impairing that might not necessarily check the box of that anxiety disorder diagnosis. And so I think it's important that we think about anxiety diagnostically or categorically, but also think about it on a spectrum. And so we tried to do that with some of the work that we did a few years ago, where we looked at 205 individuals with tic disorder from 2 different tertiary care sites. And we looked at self-reported anxiety symptoms using a validated self-report measure called the MASC. And what we found was that in those with a tic disorder diagnosis, clinically significant anxiety symptoms were quite common. And this was in a group of individuals not selected for anxiety symptoms, just for tic disorder diagnosis. And we found in this sample that separation anxiety symptoms and panic symptoms were particularly common. Another interesting thing that we found was that there might be some differences in how anxiety symptoms look in those with tic disorder compared to those without tic disorder. So in children in the general pediatric population who have anxiety disorder, what we typically see is that in children or younger children, it's more common to have a separation anxiety disorder. And that becomes less common as they get older into adolescence. And what tends to happen in around adolescence or later childhood time is that social phobia becomes a bit more common. What we found in our sample of individuals with tic disorders is that regardless of whether children were in the younger childhood group or in the adolescent group, they had pretty high rates of separation anxiety symptoms, but they also had high rates of social phobia symptoms. So it seemed like there wasn't this sort of transition period depending on the age that we see in the general pediatric population. I mentioned before that anxiety is something that might start early in tic disorder. So this is a figure taken from a Herstritz paper where they looked at over 1,000 individuals with tic disorders. And they looked at a number of items, including different co-occurring conditions, and looked at the age of onset of these conditions. So what you see here in the graph is that along the x-axis is the age of onset in years. And then along the y-axis are the different symptoms or disorders that they looked at. I highlighted in red the anxiety disorder one. This type of plot, the way that you read it or interpret it, is that the width of the area shown there is proportional to the number of individuals who had onset of symptoms at that age. And so as you can see, there's an area of a wider area in the anxiety symptom range that's around 4 to 7 years. So anxiety symptoms have a high risk of onset in tic disorders as young as 4 years of age. But as you can see, it extends quite far out, this line. So even though the onset might be common in this young childhood period, it could start really at any point in life, especially in adolescence, young adulthood. So what this tells us is that anxiety is something that we should screen for early. We shouldn't say, oh, this kid is too young, they probably won't be anxious. But we also should screen for it often so that if somebody didn't seem like they had problematic anxiety at their first visit, they might by the following year, for example. So then how do we assess for anxiety in Tourette syndrome and other tic disorders? Well, there are specific screening forms that we can use, and these are ones that are not specific to Tourette syndrome, but are used in the general population. In children, I'll often use the SCARED, the Screen for Child Anxiety-Related Emotional Disorders. It's, it comes in English and Spanish. It's free. There's a child version and a parent version, and it's good for ages 8 to 17. So it's a really nice one to use. But there's also a nicely validated RCAD, which is an anxiety and depression scale that can also be used. In the adult population, we'll often use a GAD-7 to screen for anxiety in that group. And then in addition to that, especially again for children, since that's who I will typically see in my office, is that we ask some general questions in the office. Do you worry more than other kids your age? Do you have a hard time falling asleep at night because you can't turn off your brain? Are there things that you avoid doing because of your worries? And then for tics specifically, one clue to me will be if somebody has tics that aren't really that noticeable and don't seem that impairing to the child's function, but they're very concerned about the tics because they're embarrassed by them. That clues me into there might be some anxiety there too, since they're more worried about the appearance of the tics than the tics being annoying or impairing or painful. And for a visit with a child or adolescent, it's really important to ask both the child and the parent because they can have different views, but they're both valuable and can really help to inform your assessment for anxiety. So then to move on to talking about the anxiety-tic relationship, this is an area that I think there's still more work to be done, but it's very interesting. So we know that there is something about anxiety and tics and how they're related. And one way that we know that is the experience of individuals with tics during periods of stress or increased anxiety. I will typically counsel patients before the start of the school year that, hey, typically kids with Tourette syndrome will have increase in their tics for the first couple weeks of school. And that's often some increased stress, some anxiety, even if they're excited about school, and that will typically level out. So there's that sort of knowledge on the ground of what tends to happen. And then there's been some work done looking more into that relationship and what that relationship is. So from work done by Coffey's group back in 2000, they looked at almost 200 youth with Tourette who were referred to a psychiatric clinic. And they evaluated for different anxiety diagnoses, and they categorized them based on the type of anxiety disorder diagnosis. And they also classified based on tic severity. They decided, are they mild, moderate, or are they more severe? And what they found was that most non-OCD anxiety disorders were associated with a more severe tic disorder. And this was particularly striking for separation anxiety. And then they also found that if you look at the number of anxiety disorders that somebody has, those with more types of anxiety disorder diagnoses were more likely to have a severe tic disorder presentation. And that's what's shown in the graph here on the left. The x-axis is the number of anxiety disorder diagnoses, for example, separation, anxiety, social phobia, etc. And the y-axis is the percent of individuals with severe tic disorder. And as you can see, as you go up in the number of anxiety disorder diagnoses, you tend to have a greater representation of those with severe tic disorder. Why is this? It's not entirely clear, but it's possible that it's related to the hyperarousal that can occur from anxiety. And that hyperarousal might affect the circuits that go through the basal ganglia that are thought to produce tics in the brain. So another way to think about this is to think about the neurobehavioral model of tics. The neurobehavioral model of tics says that tics are neurally based, they come from the brain, but there are outside environmental influences that can impact this. And what's thought to occur is there is an urge, the premonitory urge, that most people with Tourette syndrome will describe for at least some of their tics. The urge is described as this aversive sensation. It might be near the tic, it might be the full body, depends on the person, but it's a feeling that's uncomfortable and tends to build, build, build. Somebody performs the tic and they feel relief from that urge. And then that urge will often come back and the cycle will continue. That experience where the individual has a tic and there's that feeling of relief creates a negative reinforcement cycle. And that negative reinforcement cycle is thought to perpetuate this production of tics. This is sort of similar to what is seen in individuals with OCD when obsession-induced anxiety is neutralized by compulsive behaviors. And so that's thought to be the central maintaining variable for tics in individuals with Tourette syndrome. This is also what the primary behavioral treatment is based off of. So the primary behavioral treatment that we recommend is called comprehensive behavioral intervention for tics. There are a number of components to this, but one, I'll forward here. One of the key components is habit reversal therapy. So habit reversal therapy teaches the individual to recognize that urge and then develop a competing motor response that breaks the urge-tic relationship. And the proposed neurobiology behind this is that if you are doing this competing motor response, this is a competing motor pattern going through the basal ganglia, so that the basal ganglia is then better able to inhibit the undesirable motor outputs, which it should be doing when it's functioning optimally. And that undesirable motor output would be the tic. But comprehensive behavioral intervention for tics has other components to it as well. So there's psychoeducation, there's functional interventions and relaxation techniques, as well as the awareness training and competing response training that's part of habit reversal. So as I was describing before, CBIT should really inhibit that urge-tic relationship because you have that competing motor response that goes through. Well, how does anxiety play into this? The landmark CBIT trial that showed that CBIT was effective for decreasing tic severity in individuals also looked at moderators or mediators of response. these interventions. And one thing they found was that having an anxiety disorder diagnosis predicted a lower tick treatment response. It was both in the CBIG group and in the other group, but it tells us that when anxiety is present, it might be harder to treat the tics overall, particularly at least with behavioral therapy or psychoeducation types of methods. And so it's an interesting way for us to think about how those interact and how we might be able to capitalize on the presence of anxiety to better enable the treatment of tics. I wanted to switch gears a little bit and talk now about the impact of anxiety, because I think that it has a striking impact on individuals with tics, both youth and adults. And it's important to think about the ways in which it can impact individuals so that we know how to better assess the impact on our patients. So there has been work that shows that there's a negative impact in youth with Tourette syndrome. So in some of the work I described from our group from before, one thing we did look at was symptom severity of different co-occurring conditions and the relationship between that and quality of life in youth with tic disorders. And we found that anxiety symptom severity as reported by the child was associated, or greater symptom severity was associated with worse quality of life. In a group of adults, Adam Lewin's group had looked at the relationship between tic severity and functional impairment. And what they found was that the severity of anxiety and also depression symptoms moderated that relationship, such that those with greater anxiety symptoms seem to have even more functional impairment from their tics. And so I think it's important to think about the way that these symptoms can impact our patients. And then in a mixed method study done by Cuenca's group, they talked to children and they talked to parents of children with tic disorders and found that in both the children and their parents, management of anxiety and negative emotions related to tics were thought of as being very important to them and prioritizing how we manage symptoms. So I want to think about some different major components within impact and functional impairment in youth with Tourette syndrome and other tic disorders. So first we'll talk about family. So work done by our group that I had mentioned earlier looked at anxiety symptom severity and the impact on the family. And what we found is that actually anxiety symptom severity was not associated with family impact as measured by a family impact module. But in other work done by Robinson's group, they looked at a national sample and found that there was a relationship between family function and severity of both internalizing symptoms and externalizing symptoms. And internalizing symptoms include those symptoms such as anxiety. And so I think it's important that even though our work hadn't shown a clear relationship, the other work has, and then it might be that the way that we assess the impact would be different depending on the types of symptoms present. And it's also possible that anxiety symptoms might impact families differently from other types of psychiatric symptoms. So one area that our study had not looked at that I think is really important and key to keep in mind is that of family accommodation. So family accommodation, these are the changes that family members make to their behaviors or their actions to either lessen or prevent distress in the anxious child. So for example, if a child gets really anxious eating around their family members and they don't want to be part of that, they say, okay, you eat in this separate area at a different time and we'll have our family meal later. We don't want to stress you out or make you anxious. And while that seems like a helpful thing to do because you lessen the child's anxiety, what we find is that can be problematic. So we find that in individuals with anxiety, and this is all comers, not just tic disorders, family accommodation is quite common, but it also contributes to the maintenance of anxiety. And work that's been done by other groups have shown that the more family accommodation that's present in a family, the greater the symptom severity and also functional impairment in the family. And so it's really important when we're thinking about impairment of family, it's not just, you know, is there a negative impact on the family, but what do you do differently as a family because of your child's anxiety? family accommodation has been looked at in Tourette syndrome, and it's thought that some of the accommodation might be due to worry about the negative consequences of tic symptoms. So some of it might be related to the tics themselves. And in a group of 75 youth with Tourette syndrome, Storch's group found that family accommodation was present in the majority of families. And they found that, again, in this cohort, that both anxiety and externalizing symptoms predicted family accommodation. And this was when you controlled for the tic severity. So no matter how severe the tics were, anxiety and externalizing symptoms were predictive of family accommodation. So again, I think it's something just interesting to think about and important to assess in our patients. Another important area to think about in terms of how anxiety affects an individual is the social impacts. So in the 2022 Tourette Association of America Tourette Impact Survey, they found that 38% of children reported being worried about being socially isolated due to their tics. And we know that with tics, there's the potential for stigma, and this can happen even more with socially inappropriate words or movements. And this can be coprolalia, cursing or obscene language, copraxia, obscene gestures, or it can also be non-obscene but socially inappropriate behaviors, also called NOSI. In much earlier work done by Curlin's group, he found that about a third of Tourette syndrome patients did report having social problems due to these non-obscene, socially inappropriate behaviors. And there might be some kind of impact on relationships that individuals with Tourette syndrome have. There's been work that shows that there's more relationship anxiety and relationship avoidance in individuals with Tourette syndrome. And in a mixed method study that included parents of youth with Tourette syndrome, they asked about social function and peer relationships. And in that study, the mothers tended to attribute this reduced motivation for peer interaction to things like social anxiety. So it's possible that social anxiety is playing a role in difficulty with relationships. And that social anxiety was also linked to non-participation. So their social phobia or social anxiety might keep them from participating in activities that would open them up to other peer relationships. And then when thinking about the social piece of things, you can't talk about it without also talking about bullying. And we know that patients with Tourette syndrome are more likely to be involved in bullying. And this can be involved as being a victim of bullying or being a perpetrator of bullying. But the presence of anxiety specifically is significantly associated with an increased likelihood of being a bullying victim. And so again, especially for anxious kids with Tourette syndrome, although really for all kids with Tourette syndrome, we should ask about bullying because it's important to be aware of that. Another area to think about is to think about school impacts. And in this talk, I don't go into job as much since I'm focusing a little bit more on children, but a number of these things can also tie into jobs as well. So school-related problems are common in individuals with Tourette syndrome. We know that individuals with Tourette syndrome have higher rates of learning difficulties. Tics themselves can directly interfere with school. Also, the stress of tics may interfere. And again, this brings into this a little bit of the anxiety piece of things. When somebody is really stressed or worried about having tics, that can make it very difficult to concentrate in school, and that can again affect performance. And then bullying, as I mentioned before. In work done by Bitsko's group, they found that those with Tourette syndrome were more likely to have to repeat a grade or to have a parent contacted about a school problem than those without Tourette syndrome. So what can we do to support children with school issues, particularly those who have anxiety and Tourette syndrome? The first thing we want to try to do is identify the cause of the anxiety. Is there a way that this can be addressed? Is there something simple we can do that can make it easier on the child in some way? Again, try not to do so much the accommodation, but still trying to see if we can take away the root cause of the anxiety. Another way that we can support children is to provide education to the teachers and staff. And I find this to be a really important piece of things. If teachers don't know what Tourette syndrome is, they might think that certain behavior is intentional by the child, but it might be related to their underlying anxiety and definitely related to part of what makes a child with Tourette that child. And so providing education about Tourette syndrome can be really helpful. I find it helpful to connect schools and families with the Tourette Association of America because, as mentioned earlier by Alexandra, there are a number of resources that can be really helpful. And I will directly connect my patients to our chapter president, who has a lot of experience with education and can be a really great advocate. And so having a specific person you can connect the families to can be really valuable. And then making sure there's a network of support at school. Who's in your corner at school? Who can we talk to help make sure that we can support you through this particular problem? And then there are very specific concrete things listed here. A number of these recommended from our chapter president for Greater New York State, as I mentioned before, with her education background. Sometimes kids need more frequent breaks. Sometimes they need preferential seating. It's possible that having the teacher work with managing their workload can be really helpful. So talking directly to the teacher, having the parent interface with the teacher about what we can do to manage the workload, especially during a period of increased anxiety, because really you want to focus on the quality of the work and not so much the quantity. For children who have a lot of social anxiety, getting them into some kind of social skills training or social skills group, like some lunch groups, for example, can be really helpful. Seeing if there's a way that for children who get overloaded by a lot of sensory input, if there's a way to avoid some of those more high sensory overload areas. And then it's possible for some children that they need a home-based learning kind of program for a period. And we try to avoid that if we can, because we want the child to be able to function in their typical setting, but for some children, it's just not possible for a period of time. And so when this kind of home-based learning program is set up, we try to do it along with a plan for reentry. So now switching gears over to how we manage anxiety and Tourette syndrome. So this is actually similar to how we manage it in individuals without Tourette syndrome. We don't have specific studies on management or the best way to manage it, specifically in individuals with Tourette syndrome. But we find that the other typical kinds of methods do seem to be helpful. And those can include medications and non-medication options, and it's also important to always think about combination treatments as well. So when thinking about non-medication options, and again, this is really youth specific, but can be used in adults as well. Cognitive behavioral therapy has the best evidence behind it in terms of the type of psychotherapy or behavioral therapy for individuals with anxiety. So what is it? What is CBT? This is an evidence-based treatment. It can help for a number of different disorders, including pediatric anxiety. It's typically a time-limited treatment that focuses on building really specific concrete skills and helping children to adapt or change their thought patterns. So it helps them to learn how to take potentially negative thoughts and make them more neutral and more helpful. There's a big emphasis on the connections that happen between your thoughts, your feelings, and your behaviors. And so teaching children about those connections and recognizing those connections. In the largest pediatric anxiety treatment trial to date, which I'll talk about a little bit more in a couple of minutes, they found that over half of individuals had a positive response to cognitive behavioral therapy alone. And then when you combined that with medication treatment, that was even more substantial in terms of benefit. And then it's important when thinking about CBT in youth to always include the parent and caregiver in this too. So they should be involved in the therapy sessions in some way, or at least some of the sessions to get the most benefit. While CBT can be really useful, there are a number of limitations to be aware of. So there's the age-old limitation of resources. So there are a number of available trained professionals, but not as many as we need for the need that's out there for pediatric anxiety. So it might be hard to find somebody who's trained in this. It might be hard to find somebody who's trained in this who knows kids with Tourette syndrome and understands the number of different symptoms that might be interacting. Also, there can be a difference in the way that studies are done compared to clinical experience. So a research protocol CBT, like was done in the trial I mentioned before is a very specific structured protocol. In clinical practice, it's typically not quite as structured. And so you don't really know what are they getting for CBT. Is it true, tried and true CBT, or are there some elements of CBT in it? For some individuals, the frequency of sessions may be difficult. Oftentimes, it's recommended to have weekly sessions, and that can be challenging for children or families that have a number of other competing interests and competing needs for their time. Cost can be an issue, so insurance sometimes doesn't cover it, or if it does, it still costs quite a bit of money for some, so that can be a barrier. And then for those with more severe anxiety, it might not work to go just to CBT. You might need medication as well. So in line with that, well, when do we think about medications for anxiety in youth? So as I mentioned before, when somebody's unable or unwilling to participate in CBT, which can happen with very severe anxiety, they're too anxious to even engage, or perhaps they've engaged, but their response is only partial. When there are other comorbid psychiatric conditions, you want to think about medications too, but it's not necessary, but it depends on the psychiatric disorder that's co-occurring. When they're more moderate to severe anxiety symptoms, I think it can be more helpful to add a medication into it. Now, the CAMS trial, this is what I was referring to before for the largest pediatric anxiety treatment trial to date. This is a child-adolescent anxiety multimodal study. This included almost 500 treatment-seeking anxious youth, and they were randomized to either medication, which was sertraline, cognitive behavioral therapy, a placebo pill, or a combination of sertraline plus cognitive behavioral therapy. And what they found was that sertraline worked just as well as CBT. Sertraline or CBT was better than placebo. But when you combine sertraline and CBT, that was better than either alone. And so we use that a lot when we're thinking about how to approach an individual with anxiety in terms of treatment. There are a number of medications out there that can be used. In children, my first line is selective serotonin reuptake inhibitors. There are a number of SSRIs and different reasons that you might choose one over another, but this is generally a class I'll start with. Adults will also sometimes consider SNRIs. That's usually something that would be considered not first line, but could be used in pediatric anxiety. Buspirone is used not uncommonly, and then propranolol can sometimes be used as well. Benzos are something I don't typically do as management for everyday anxiety, but perhaps for periods of increased anxiety as a PRN. And then tricyclic antidepressants or TCAs can sometimes be helpful, and I'll sometimes use that if I'm also treating another condition that would maybe benefit from that medication. In a 2019 meta-analysis of 22 randomized controlled trials, they looked at trials that included individuals with generalized anxiety disorder, separation anxiety disorder, and social phobia. And what they found was that looking at all those RCTs, the SSRIs were the only class that was superior in reducing anxiety compared with placebo. And SNRIs and 5-HT1A agonists were associated with more frequent treatment response compared to placebo. So then again, it really supports that SSRIs are a good first line to start in pediatrics. It's important to think about potential side effects because you want to counsel your patients on these. GI symptom upset can happen. I tend to find this as being pretty brief and tends to resolve, but if it doesn't, something to think about. Some people will report sleep changes, so it can sometimes be helpful to change the timing of the dose, maybe to the morning or to the evening, depending on the symptoms. Restlessness can occur, headaches. Some people will report appetite changes. Sexual dysfunction can be an issue, so it's important to bring it up and talk to particularly our teenagers and young adults about that. And then some individuals will have a behavioral activation. And so sometimes these are things where you can see if things will improve with a little bit of time, but in other cases, it's a sign that you might need to change to a different SSRI. In general, a rule of thumb when thinking about medications or CBT is that if it's more mild anxiety, either one would be fine. And if it's more moderate or severe, it's typically best to combine if you can. For monitoring for anxiety, what you do once you've started somebody on a medication or started them on some kind of therapy, if they're on medication, you want to look out for side effects, like I mentioned before. You also want to monitor for benefit of treatment. Is this helping? And it can be helpful to check in and meet with them. But sometimes those rating scales, if you had them fill it out early on, can be helpful to repeat just to kind of see, are we seeing a change at all here? It's always helpful to communicate with the treatment team. So perhaps you're not the one prescribing the medicine, but you want to know how it's affecting them overall. So it's helpful to always have that open communication. And then if you're the one, prescribing a medication, or if they're getting therapy for any reason, it's important to assess for depression because that can often come along with anxiety, especially in older groups, and then suicidality as well. And so just to summarize what we talked about today, anxiety is common in individuals with Tourette syndrome, youth and adults actually. It's something that can start early but often persists. There's a relationship between anxiety and tics. And we know that anxiety and Tourette syndrome can have negative impacts. It can affect the family, it can affect peer relationships, and it can affect education. There are options for managing anxiety. They can include psychotherapy such as CBT, SSRIs, or perhaps other medications, or a combination. And so with that, I want to open up for questions and also ask that individuals, if you can scan this QR code and complete the survey, that's always very helpful for us to continue these webinar programs moving forward. Thank you.
Thank you so much for the presentation. Yes, as was just said, if you could please use the QR code, or you will see in the chat, I also put in the link as well, just in case for some odd reason that did not work. These surveys are really important to the CDC to help us continue our presentations and having them fund them. You can also see in the chat as well that I've included an email to reach us out if you have questions, our website, and if you're looking for credits for this presentation, the steps to do that as well. I am going to now pull up our questions. So the first question actually asks for if there would be a copy of the presentation being provided. This is recorded and it actually will be available through us on our YouTube channel, so you will be able to access it there. And I'm waiting to see any more questions coming in. All right. We have a question, which is, how as a parent do we distinguish between eliminating the root of anxiety at home that can perpetuate symptoms versus eliminating the root of anxiety at school?
So that's a really good question to ask, and sometimes can be challenging because there can be different things that seem to cause an anxious reaction. So I think a lot of it is partnering with your child on it. And first is kind of observing things. So at home, figuring out what tends to trigger your child. Sometimes children's anxiety will come out as outbursts. Sometimes it could be more explosive or meltdowns. Sometimes they become more drawn in themselves. So if you're able to see what tends to trigger that, that could be helpful to figure out what at home, if anything, seems to bring it on. And also always asking your child, they might have a clue or they might not. It's also a good example or opportunity for if your child is in any kind of therapy to engage with the therapist as well and say, you know, can you help with identifying this and helping my child identify what the trigger is here. At school, it's always hard because you're not there with them necessarily. So again, asking your child about it some, but then it can be also helpful to talk to the teacher and ask them to notice things and ask for their feedback. Because I think that the big answer is communication can be so helpful, and communicating with multiple stakeholders in this to figure out what is the problem or the root of the problem.
Thank you. Our next question is, what is the difference between social anxiety and social phobia? Severity? Question mark?
Good question. It is the DSM. So at some point, it went from being social anxiety disorder to social phobia. It's really not different. They can be used pretty interchangeably. The preferred term now is social phobia. So I tried to use it, but there are times where I use social anxiety instead.
Our next question is, the graph of sources of Tourette syndrome and age suggests a relationship that aging reduces effects of anxiety, etc. Do we know why?
That's a good question. So what that graph was showing was age at onset. So it wasn't necessarily anxiety severity. So it wasn't that anxiety tends to get better with age. It just tends to not have the onset later as often. So it tends to be for kids with Tourette syndrome, that kind of younger school age period, but can start in adolescence. If you actually look at over time, what tends to happen is we will find that anxiety will either continue or maybe even worsen for some individuals as they get older, which is in contrast to what we often see with tics. So, with tics, we'll often hear that a number of individuals in their later teens to young adulthood might have things stabilize or improve or even go away. And we don't tend to see that as often with anxiety if it's not managed.
Our next question asks, what percentage of children with anxiety and Tourette syndrome would you say are prescribed drugs?
That is a good question. I don't know because there's not much national data out about it for Tourette syndrome. We did look at within our consortium in New York State. We did a survey asking individuals about their use of different kinds of modalities for treatment, and about half had used medication for anxiety, but that was a relatively small sample, about 50 or so individuals. So I'm not sure nationwide how many will use it because I think different people have different kind of prescribing practices. But I would like to know. I do think that's a really interesting and important question.
Well, not a question, but a flattering ask. I think we have someone who says, would you consider relocating to the Mid-Coast in Maine to treat a family member of theirs? They've enjoyed the presentation. So.
Oh, that's very sweet. I have family in Maine, so.
Else I would mention it. I think that's lovely. The next question we have is, so should the root of anxiety be addressed at school and tried to be eliminated to help with school progress, or does that also perpetuate things? Is there a difference? Where is the balance so not to increase mental health worries versus not enforcing anxiety symptoms?
Yeah, it's a really hard balance to strike. And I find that doing one, so you need the help of managing the anxiety as well. So for my patients, with the school kinds of accommodations, my goal is to have that be sort of a short-term thing as we're trying to manage the overall anxiety symptoms that they have. So we might say we need to decrease workload a little bit here. Let's just send home some of the very necessary assignments, or say they need to take more breaks during this time. And yes, that is a degree of accommodation, but it's for this kind of short-term period. You try to make it sort of a defined period as you're trying to manage the symptoms too. With the family accommodation at home, we'll sometimes see is this just becomes the routine, like forever for individuals. And so if you do that, you say, well, it's not really affecting us, it's not causing a problem. But when you think about all the different things that one has to do at home to make everything okay for the child, then you realize that it actually might be impacting them more and perpetuating the anxiety. So then it's working with a good counselor to help figure out how to decrease the family accommodation while also helping to manage your child's anxiety. It's not suggesting that you just like stop everything all at once, because we know that that's really hard too and probably wouldn't be beneficial, but it's sort of a scaling back as you help increase their skills of managing and coping with their symptoms.
Next question asks, would you be worried that a child's anxiety would worsen when an SSRI or SNRI is started in a child with Tourette's and comorbid anxiety?
Sometimes, so we will find, and this is in anxiety in general, so not just in Tourette syndrome. Sometimes kids, when they start an SSRI, will initially have a little bit more anxiety. So as long as it's manageable, I ask to give like a week or two for things to settle out. Now, if things haven't settled out and it's not working and it's worsening things, then we stop that one and we'll give a little break and then usually try another one. The hard thing is that we don't have a great way to say this is the perfect SSRI for you. There are some genetic tests that can be done that can be helpful, but even that isn't always like, this is the perfect one for you. This is the one we should start with. So it can be challenging. There's a little bit of trial and error that can happen. I would say that the worsening of anxiety is not super common, but can happen.
Our next question says, do we have a definitive understanding of the neurological base of anxiety?
We do have a good understanding of it. So we think about, there's an area in the brain called the limbic system, and the amygdala is a specific place in it where you kind of have this fear generation. So the amygdala is thought to have a lot of involvement in anxiety. What we don't fully understand is how those systems interact with the tic systems, and if they do, I think they do in some way, but if they do, to help kind of perpetuate or worsen tics in those with anxiety. That part we don't understand as well.
And our next question is, are children diagnosed with TS eligible no matter what because of their diagnosis for an IEP, or does that depend?
It depends. So a child with Tourette syndrome is considered covered under the Americans with Disabilities Act, so that they are able to be assessed for additional supports. And that's not necessarily an IEP, but they do have the right to be assessed to see if they would qualify for a 504 or an IEP.
Awesome.
And so as a parent, at least in New York State, I don't know necessarily the other states, but I know in New York State, as a parent, you can request that from the school, and they will need to do testing and assessments to see what they qualify for.
Amazing. Well, I want to, in the interest of time with our 1 minute left, I do want to take the time to thank you so much for your presentation, Dr. Vermillion, and I want to thank everybody who came, everybody who asked questions. We really appreciate them, and we appreciate everybody's time, and thank you so much.
Thank you, everyone. Thanks for coming.
Have a great rest of your day.